One of the biggest risks with atrial fibrillation is the possibility of stroke. Dr. Pete, how can we reduce that risk?
You're right to make sure that people get this one right, Lindsay. The prime directive, in my opinion, of the management of patients with atrial fibrillation is to preserve the brain or prevent strokes. If you don't get this one right, everything else falls by the wayside. And strokes occur when clots in the upper left chamber leave that area and they go to the brain, as seen in this animation. Note in this particular figure that there is a heart in atrial fib, and you can see inside the left atrium a clot's present there, or it's sometimes called a thrombus. If this clot dislodges, as you can see in this figure, the next thing is the highway to the brain. It goes up the arteries from the heart into the arteries that go to the brain and can cause devastating complications. Now, not everyone is at high risk for stroke, and a system to characterize stroke has been developed. This system isn't perfect, but it's the best one we currently have. It employs several risk factors, and it's called the CHADS-VASC system. However, this modification is of the initial CHADS-2 system that used less risk factors. So let's take a look at this and go through what each letter stands for. C is congestive heart failure, H is hypertension, age is broken down into those 65 to 74, and then over 75 gives you greater risk. D are those who have diabetes. S means you've had a history of a stroke or even what's called a transient ischemic attack. And V equals vascular disease, for example, coronary disease. S equals the sex category, that's female. But as new information came about, female gender doesn't really by itself add significant risk to stroke, so now that's been crossed off. Now, with this risk stratification scale, through research that's been done, you basically add up numbers, okay? So if your number is at least 2 for a man or 3 for a woman, you meet criteria that you should be offered anticoagulation.
Now, what about patients who have no risk factors that I might presume you would label a 0?
Yeah, and that's also very important because you don't want to over anticoagulate people. In other words, put people even at a small risk of a bleed when they aren't going to derive enough benefit from the blood thinners. And if you have a 0 risk score, the recommendation is that we do not offer you routinely anticoagulation treatment. But the troublesome group, the really gnarly group, are those patients who fall in between, because these risk stratification scores are based on the risk of a stroke compared with the risk of the blood thinner, because there is a small but finite risk factor for any blood thinner. And when you have the higher scores, the risk of a stroke is far more evident than the risk of bleeding, and therefore there's no question they should be recommended a blood thinner. But for patients who fit into that in-between group, where the risk of stroke is clearly there, but the risk of bleeding is also there, and the separation of the two is not as great, that's the one where you really need to sit down with your doctor and have a detailed discussion. And for me, it often comes down to a discussion with the patient: what worries you more, a bleed or a stroke?
Absolutely. And of course, you have to have the discussion about potential types of drugs. What can we use to reduce stroke risk?
Yes, absolutely. The anticoagulants or blood thinners are the standard form of treatment for preventing strokes. And several oral drugs are currently available, and they're listed on this figure. Which one is best for each patient should be discussed with their physician. There are also newer devices available that work as well as, not better than, drugs. And some of them are shown on this figure. And what they do basically is to block off that left atrial appendage where 90 to 95% of all clots develop that can cause a stroke. They are very effective for that, and they are particularly useful in patients who have a hard time with blood thinners. But again, that kind of discussion needs to go on between you and your electrophysiologist.
There is so much to cover here. So next we'll be moving into what you are calling the most complex topic, rhythm control.